Hello, my name is Walter Mack, and today we'll describe a brief approach to interpreting an MRI of the elbow. So in general, my checklist would include the lateral elbow structures, i.e. the radial collateral ligament, the lateral ulnar collateral ligament, and the common extensor tendon. Then on the medial side, I would look at the anterior bundle of the ulnar collateral ligament. We'll talk briefly about the posterior and transverse bundles, although that does not form a major component of the analysis. And then the common flexor tendon also on the medial side. Then I look at the biceps brachialis and triceps tendons. All right. Then I look at the radiocapitellar and ulnar humeral joints. We assess cartilage, much like we would in the knee, for example, and look for osteochondral lesions. Here, I think we will touch upon one or two normal variants that can simulate pathology. Then I look at the nerves, so median, ulnar, radial nerves, and select branches. Then I look at the regional musculature, and then we finish off, as with all the other joint examinations, looking at Merrill's signal, looking for incidental masses, so on and so forth. And so what I have here is an axial T2 sequence, T2 fat-sat sequence through the elbow, and here is a coronal PD fat-sat sequence. Once again, it can be hard to distinguish between a proton density fat-saturated sequence and a T2 fat-saturated sequence, so we'll just refer to them as fluid-sensitive sequences, and these will be the workhorse sequences of your typical sports medicine MRI, as is the case here. So let's look at the lateral ulnar collateral ligament, radial collateral ligament, and common extensor tendon. So keep in mind that, as in the ankle, ligaments are deep to tendons, and I think if we remember that relationship, it becomes easier to sort out these individual structures, particularly on the axial sequence. So let's actually start with the axial sequence. So here's the lateral epicondyle. Okay, so you're going to see, as the most superficial structure, the common extensor tendon coming off, and it will eventually give rise to the extensor digiti minimi, extensor digitorum, extensor carpi ulnaris, and extensor carpi radialis brevis tendons. And we assess this just like any other tendon in the body. So if it's homogeneous low signal, it's normal. If it's heterogeneous intermediate signal, we'll call tendinosis. If we see fluid signal, then we're going to start calling tears, either partial or complete, and you may see avulsive stress edema. And it's important to cross-correlate with multiple planes to ensure that what you're seeing is indeed pathology. Here, I do see a little bit of gray, so I might be tempted to call some mild common extensor tendinosis. Immediately deep to the common extensor tendon will be your radial collateral ligament and your lateral ulnar collateral ligament. And just briefly, I want to pull up the sagittal sequence corresponding to this region. Okay, so here we go. And I just want to press upon you how intimate the radial collateral ligament origin and the lateral ulnar collateral ligament origin are. So not unusual to have tears of both structures with the common extensor tendon when you have lateral-sided elbow pathology. So it should not be unusual to call multiple injuries to all these structures on a routine basis. And once again, the ligament should also be low signal homogeneous in the normal situation. So let's try to find these structures on the axial, and then we're going to go to the coronal as well. So here is our lateral epicondyle, here is our common extensor tendon, and as I scroll distally maybe one or two images, now we can actually see a separation of structures. So the more superficial is your common extensor tendon, and then the deeper is your radial collateral ligament, and it's going to blend imperceptibly with this ligamentous structure encircling the radial head and neck. Okay, and that's this latter structure is the annular ligament. So here's your radial collateral ligament inserting onto the annular ligament. I'll confess that I don't spend too much time assessing the annular ligament on a routine basis. Radial collateral ligament I do look at, and then to find the lateral ulnar collateral ligament, we just have to go back to where we expect the origin to be, just posterior to the radial collateral ligament, and we're just going to scroll slightly distally from that point, and you're going to start to see this ligamentous structure that curves around the back of the radial head and neck and inserts upon the supinator crest of the proximal ulna, and here it is. Here it's this guy right here. So that's your lateral ulnar collateral ligament, and keeps the radial head and neck from popping out posterolaterally from the rest of the elbow, or preventing so-called posterolateral rotatory instability. Let's try to find this ligament on sagittal. So here we are, far lateral sagittal image. Here's our lateral ulnar cloud ligament, and it's going to come around the back here. It's going to cranial, that radial head and neck, and then it's going to insert onto the supinator crest. So here's the supinator crest of that proximal ulna, and then so it's this ligamentous structure here. But really, I would probably use predominantly the coronal and axial to assess the lateral ulnar cloud ligament. Here is that lateral ulnar cloud ligament in coronal perspective, and if you read articles on this, they'll probably show you a picture like this when they're talking about the lateral ulnar cloud ligament. You can just imagine how it prevents this radial head and neck from slipping out this way, posterolateral. Okay, so that's the lateral side. Now let's look at the medial side, and we'll stay on the coronal. So here is the anterior bundle of the ulnar cloud ligament. It's the key restraint to valgus instability of the elbow. And I just want to point out this heterogeneity here at the near the medial epicondylar attachment. This is actually normal, and so you'll just have to accept a certain amount of signal heterogeneity at the proximal attachment of the anterior bundle of the ulnar cloud ligament. And as you see more and more of these cases, you'll get more comfortable with what's normal, what's abnormal. Contrast that with the insertion at the sublime tubercle of the coronary process. This should be very tight, tightly applied to that coronary process, and there should not be any signal, high signal, insinuating between the distal attachment of the UCL and the bone. If there is, then that's a partial tear. And one of the classic findings on an MR arthrogram of the elbow would be that of the so-called T sign. So you can imagine if there was some stripping away of that ligament from bone, you would see an inverted T like that, all right? And the T would be, the part of the horizontal part of the T would be contrast insinuating between the ligament and bone. So that would be abnormal. This is normal here. See how there's a nice tight attachment. If we were to scroll more posteriorly, we would actually get into fibers of, sorry, that's anterior. We would actually get into fibers of the posterior band of the ulnar cloud ligament, and this is a fan-shaped structure that goes from the medial epicondyle to the olecranon, and it's thought to provide some stability when the elbow is flexed beyond 90 degrees, but I'll confess I don't spend too much time looking at the posterior bundle, and I spend no time assessing the transverse bundle, which basically connects the medial olecranon to the inframedial aspect of the coronary process. So you can just imagine it'd be a structure that kind of runs like so. So transverse bundle I don't think is terribly important. Let's go to the axial for a second here. And so here's the medial epicondyle, and to find that anterior bundle of the ulnar cloud ligament, we scroll slowly distally, and you're going to see a ligamentous structure that is just inferior, that comes off just inferior to that medial epicondyle. So it's this guy right here. Notice how this ligament is actually deep to the nearby common extensor tendon. So once again, ligaments deep to tendons, and we're just going to slowly follow this in, and you're going to see it attach right there. So this is the attachment to the ulnar cloud to the sublime tubercle of the coronary process, this guy right here. And then once I think you've got that perspective down, then it gets easier to correlate with your coronal sequence and make sure that what you're seeing is indeed that anterior bundle of the UCL. We had mentioned the common flexor tendon in passing. Here is the common flexor tendon origin, giving rise to pronator teres, flexor digitorum superficialis, flexor carpi radialis, flexor carpi ulnaris tendons, and ultimately muscles. And notice how it comes off quite a ways peripheral from the ulnar cloud ligament, once again off the medial epicondyle, and when it's normal, it's homogeneous low signal, heterogeneous intermediate signal tendinosis, fluid signal, we start calling partial tears or complete tears if it involves the entirety of the common flexor tendon origin. Not unusual to have pathology of the common flexor tendon as well as the anterior bundle of the ulnar cloud ligament together. Great. Later on in this tutorial, we'll talk briefly about some of these muscles. I don't think it's critical to know all the muscles, and usually if it's one of these other muscles that doesn't have a characteristic appearance like the supinator, then even I have to look up very quickly what muscle it is. But we'll talk about some key ones that might help you by serving as a landmark. So we looked at the common extensor tendon origin, we looked at the lateral ulnar cloud ligament, radial cloud ligament, we talked about annular ligament very briefly, then we switched to the other side, we looked at the common flexor tendon origin and ulnar cloud ligament. Now let's look at some of the regional tendon attachments, and I think we can start with the axial sequence here. And you're going to see, so this is, let's start just above the elbow. So here's our biceps muscle, here's our brachialis muscle, and you're going to see both tendons form. So biceps, as you can see, biceps once again is kind of radial relative to the median nerve and the brachial artery and vein. So here's the biceps, and you're going to see it go to the bicipital tuberosity. There it is, and it's a fairly easy structure to assess. So ditto for brachialis, inserting onto the proximal ulna, and then finally the triceps tendon, which looks a bit like a quadriceps tendon. So let's just pull up the sagittal here, and note that the triceps tendon also has a somewhat striated insertion, very analogous to the quadriceps tendon. So try to appreciate this striated appearance as you start to look at more elbow MRIs, so that you can develop in your mind a normal database of how much increased signal in this location is acceptable. Note too that the triceps has superficial and deep fibers, alright, arising from the three heads of the triceps tendon. So make sure when you see a tear that you ask yourself, is this a full thickness tear or is this partial thickness tear? Here's the anconeus muscle. It's an easy way to tell you which side of the elbow is lateral. Also notice the more protuberant medial epicondyle, and then sometimes you have other easier clues, like here is the ulnar nerve in the cubital tunnel, for example. Okay, so we looked at flexor and extensor tendon attachments, we looked at the cloudal ligaments, we touched briefly upon the regional tendon attachments, and it's around this time that I start looking at the joint itself. All right, so let's you know what? Let's look at the axial T1 first, and notice how we have fat pads in the cornoid and olecranon fossa. Notice how they're closely applied to the bones. So this is what we expect to see, and when there's joint fluid, where's our sagittal sequence? When there's joint fluid, as you learned when looking at plain films, you're going to have displacement of these fat pads. So you have displacement of, say, the cornoid fossa fat pad superiorly, you get that so-called sail sign on plain film. And of course, as you know, we should never see the posterior fat pad. If we do, that implies it's been distended by joint fluid, and that's well and good from radiography. Let's talk about some variants here. If I look at a far posterior coronal image of the elbow, that's a good example right there. So let's look at the lateral side here. If we look at the lateral side here, it can look like there's a lot of heterogeneity and a lot of irregularity of the subchondral bone plate of what looks like to be the capitellum. But notice where my localizer is. It's actually quite posterior. So this in fact represents the junction between the capitellum and lateral epicondyle, and it has this normal irregular appearance. Alright, so don't mistake this for an osteochondral lesion. Typical osteochondral lesions will be more anterior, and Panner's disease being an osteochondrosis of the capitellum, also classically happens anteriorly. So here's our capitellar articular surface, and then the pseudo defect of the capitellum, notice how much more posterior it is. So nice intact cartilage anteriorly, pseudo defect of the capitellum posteriorly, normal variant, don't call this pathology. We look at the ulnar side, and as we are at the margins of the ulnar-humeral joint, you will see these well-defined notches, alright? And you'll see one on the medial side, and you may see one on the lateral side as well. There's a bit of it right there. And note that it's at the very margins of the trochlear groove. Okay, so there's again the medial side, there is the divot on the radial side or lateral side, and these are not to be misconstrued as pathology either. So having gotten the normal variants out of the way, now we can actually assess the cartilage. And so as in other joints, the cartilage is going to be this intermediate signal that's smooth. Note that some of the black signal subjacent to the intermediate signal is also in fact cartilage as well. And we assess cartilage just like we do the cartilage in other joints in the body. So for example, if we see focal or diffuse areas of signal heterogeneity, I would argue that this radicapitalar articular cartilage is fairly homogeneous, but if there's heterogeneity, then we would call that mild chondrosis or grade 1 chondrosis. If we see thinning less than 50%, some might call that grade 2, or I would call that moderate. If we see thinning greater than 50% thickness, I would call it grade 3 or moderate again. And then if we see bone changes, subchondromerular edema or cyst formation, that would imply that there's full thickness cartilage loss, and that would be considered severe or grade 4 chondrosis. I'll leave it up to you whether or not you decide to numerically grade your cartilage. Some of our arthroscopists do, so I don't think it's inappropriate to. It will depend on what the practice pattern at your site is. And I also do like to give some indication as to whether the cartilage involvement we note is focal or diffuse, and in this case you should also indicate whether you're seeing it in the radiocapitellar articulation or the ulnohumeral articulation. Alright, there's also a proximal radioulnar joint as well, and so it's important to remark upon the cartilage in that compartment as well. And then just look for an effusion, so on and so forth. If you believe there is a joint-centered process, then of course that will be an extra half a paragraph or a paragraph in your dictation. Okay, so we looked at the common flexor extensor tendons, collateral ligaments, we looked at regional tendon attachments, and we looked at the elbow joint or joints, and it's around this time that I'll start looking at the nerves. So let's see, identification of nerves of course is greatly facilitated by identifying and following perineal fats. So I think a lot of the analysis can be done on your axial T1 sequence, axial T1 plane sequence, right? And let's start with something easy like the ulnar nerve. So an easy place to find the ulnar nerve, of course, is at the cubital tunnel. So here is the medial epicondyle. This is the Osborne ligament, so this is the roof of the cubital tunnel. In I think up to 10% patients, you can actually have an Anconius epitrochlearis. It's a normal variant muscle. Okay, so you would be able to diagnose it if you see a muscle here and you don't see a ligament here. If you do see the ligament, then what you may be confusing for the Anconius epitrochlearis may well just be the medial head, the triceps muscle. All right, and that is something that could potentially contribute to cubital tunnel syndrome. So basically anything sticking into the cubital tunnel can contribute to so-called cubital tunnel syndrome. And you see here there's a strategically positioned osteophyte coming off the olecranon. It's a sort of osteophyte where anywhere else you'd say no biggie, you might not even report it, but I think in this strategic location, well worth reporting because it may be impinging upon the ulnar nerve. Alright. As we go more distally, you're going to see a single muscle that encircles the ulnar nerve. That's the flexor carpi ulnaris. And then more posteriorly is the flexor digitorum profundus, and both these muscles are innervated by the ulnar nerve. So that's a helpful memory aid. We go more anteriorly, here is flexor digitorum superficialis. And then here, the big beefy extensor muscle here is brachioradialis. Alright? And that is a nice landmark for the radial nerve. Alright, so here's the oh, pardon me, this is the pronator teres. Okay, so let's see, I've got things backwards here. Yep, so let's rewind here a few steps here. So flexor carpi ulnaris, okay, flexor digitorum profundus, okay, that much is clear, flexor digitorum superficialis, alright, and then this is the pronator teres, okay. So the pronator teres is a great landmark for the median nerve, not the radial nerve, the median nerve, alright, and here is the median nerve. So there's hard to see the nerve itself, but the perineal fat around the nerve I think is fairly readily identified on your T1 weighted sequence. And if you look very, very closely, there's actually another slip of muscle that goes deep to this median nerve, and that's actually just the um, ulnar head of the pointed arteries. So the nerve can actually become entrapped between the two heads of the pointed arteries, right? But that results in a pain syndrome. There's no motor deficit, so you won't see any other imaging evidence of pronator syndrome, as it's been referred to. All right, so that's the ulnar nerve. We touched briefly upon the median nerve. Let's look on the contralateral side now. So this is the brachioradialis muscle here on the lateral side. So once again, pointed arteries on the ulnar side, brachioradialis on the lateral side, and the brachioradialis is a great landmark for the radial nerve. So I find brachioradialis, and usually deep to the muscle you're going to see perineural fat, and within that perineural fat is going to be the radial nerve. All right, and as we go from the level of the elbow to distal, what we'll see is we're going to see some nerve fascicles separating from the radial nerve and interdigitating within the substance of the supinator muscle. The supinator muscle is a great muscle because it has a very characteristic appearance, so it's an easy one to remember. So once again, note the perineural fat around the radial nerve. Okay, and this is the posterior intraosseous nerve. So this is the motor branch of the radial nerve, and this is going to go ahead and innervate all of your common extensor, all your extensor muscles. So if you see, say, and you see this not infrequently, say there's a deep lipoma in the supinator muscle, what you might see is denervation, edema, or atrophy of all these extensor muscles. All right, so supinator muscle, brachioradialis, and then here we get into, I believe this is extensor carpi ulnaris extensor digitiform, and then we're getting into extensor carpi radialis brevis. But these are muscles that I think you can, for now, you can probably just refer to them as the extensor muscles. There is an anterior intraosseous nerve as well, which comes off the median nerve. It's a little harder to see. It's something that you'll see kind of branch off if you're lucky, and it's going to make a beeline. It's going to go deep, and it's going to run along the anterior aspect of the intraosseous membrane. I find it's really hard to see routinely, but the anterior intraosseous nerve also is a pure motor nerve, and it's going to innervate the flexor pulsus longus, the quadratus muscle, all right, and the pronator quadratus muscle, that's right, and I believe it's the radial half of the flexor digitiform profundus. So while it may be difficult to see the nerve itself, you may see evidence of anterior intraosseous nerve compression or structural integrity by looking for denervation, edema, or atrophy in these three muscles. Again, pronator quadratus, flexor pulsus longus, and radial half of the radial muscles of radial supplied muscles of flexor digitiform profundus. All right. So we looked at the common flexor and extensor tendons and collateral ligaments. We looked at the triceps, biceps, brachialis tendons. We looked at the radicapitalar and ulnar-humeral joints. We touched briefly upon the ulnar median radial nerves and anterior and posterior intraosseous nerves. We looked at some of the regional musculature. And now it's around this time that I think it's worthwhile to have a quick look at the marrow signal throughout and ensure that there are no mass lesions and that what we see is appropriate marrow signal. There shouldn't be too much red marrow in the elbow. It's fairly peripheral in the appendicular skeleton, so it makes reading the marrow usually fairly straightforward. And at this time I would also look for incidental lesions, either mass lesions, collections. You do have a bicipital radial bursa, so this is a potential bursa that is interposed between the biceps tendon and the radiotuberosity, and it can fill fluid, and it would be fluid insinuating right between the biceps and that radiotuberosity. And the rec not uncommonly will say query mass and cubital fossa, and so being able to localize fluid signal in this location will allow you to confidently diagnose basilar radial bursitis, and this can happen at ultrasound as well. There's another bursa that is in the region of the proximal radial ulnar joint. That's the intraosseous bursa, and that would be kind of in this location here between the proximal radius and proximal ulna. Alright, so that's just a quick run through how I interpret an elbow MRI. I hope you found this helpful, and if you have any questions, please do not hesitate to contact me. Thank you.